Hello, everyone, and thank you very much for joining us for today's Lunch and Learn. Today's subject is menopause and HRT, and we know just how popular this subject is. We've got a record number of sign-ups, and that's understandable when we consider, and we still hear every day when we're running training sessions in workplaces around the confusion around HRT. Is it safe? Is it something that we should all be doing? So today we have with us Dr. Heather Currie MBE, and I'm delighted to welcome you again, Heather. Thank you for joining us and taking the time out of your busy schedule. Many of you may recognise Heather because she's often on TV. She's also the former chair of the British Menopause Society and the founder of the fabulous website Menopause Matters, which you can now get in a magazine. And I'll ask you about that later, actually, Heather, because I think my WH Smith's is always running out of it. So I'm going to jump straight in and welcome Heather and my colleague Sally, who will be answering all of your questions at the end, or as many of your questions as we can get through at the end. But welcome, Heather, and thank you for joining us. And I'm going to jump straight in and say, HRT, what is it?
So very good starting question. Thank you very much for the invitation and welcome everyone. So HRT is hormone replacement therapy, or sometimes known as menopausal hormone therapy. And what it aims to do is quite simple. It aims to replace estrogen. So the consequences of our ovaries stopping working is, and menopause actually means period stopping, but the consequences of all that are related to becoming low on estrogen. So while often the sign of our ovaries stopping working is in that perimenopause also includes changing period pattern, all the other consequences, the symptoms and the long-term consequences, are due to our ovaries just running out of egg cells and we don't produce the estrogen anymore. So the aim of HRT is to replace the estrogen, which kind of makes sense. Estrogen can be taken in different forms. It can be taken as a daily tablet, a twice weekly or a weekly patch, whereby the estrogen is absorbed through the skin and picked up by the circulation. It can be taken by a gel or also by a spray. And all these types of estrogen are called systemic estrogen. So that's then picked up by the bloodstream and circulates throughout the body. In addition, we have vaginal estrogen, which can be used to treat the vaginal and bladder symptoms of menopause, which are very common and can be distressing too. But the difference there is that's not going through your whole system. That's concentrated in the vagina and the bladder. But the other important hormone is progesterone. So if we gave estrogen systemically through the tablet, the patch, gel or spray, it could eventually cause a thickening and increase the risk of cancer of the lining of the womb. So to prevent that, if the womb is still present, we use another hormone called progesterone, which has to be taken along with the estrogen unless the whole of the womb has been removed. And the progesterone can be given combined in the tablet, or it can be given combined in a patch, or it can be taken separately as a tablet or a capsule. So the main part is estrogen, but progesterone is needed in addition in most women.
Wonderful. Thank you very much, Heather. You covered a lot there. So just thinking about the hormones, we mentioned estrogen, we mentioned progesterone, and one we hear sometimes is about testosterone. Is that part of the mix as well?
Not initially. So testosterone is receiving a lot of publicity at the moment, actually. Our ovaries do produce testosterone, but we don't suddenly produce less testosterone around the time of the menopause as we do with estrogen. Our ovaries continue producing testosterone, and we also produce testosterone from our adrenal glands. So there isn't that sudden drop off as we notice with estrogen, unless someone has had a surgical menopause. So if they've had the ovaries removed, then the ovaries produce 50% of our testosterone production. The ovaries produce the majority of our estrogen production. So removing ovaries has a bigger effect on estrogen production than it does on testosterone, but we still do lose 50%. So the indication to replace testosterone as well is fairly straightforward, though it has become confusing in recent years. But the national and international guidance is we can consider replacing testosterone for the complaint of persistent, troublesome low libido in women when all other factors have been considered. Female sexual function is incredibly complex. So there's a lot to consider and address, including optimizing estrogen, including looking at life stresses and time factor and worries and relationship issues, a whole load of stuff to consider before we should consider replacing testosterone as well as estrogen.
That's wonderful. Thank you very much, Heather. And one of the things that you mentioned was about the different types, the different varieties, because this is a question that we still get where women say, I took HRT, it didn't work for me. But you elaborated there and talked about the different types. And, you know, it may not be possible for the first one that you try to be the perfect one for you. They do need adjusting, don't they? Or you can try different ones if something doesn't work.
Yeah, so the first thing is actually it doesn't work. Let's be clear about what we want it to work for. So sometimes there are unrealistic expectations. HRT does provide lots of benefits for most women, but who choose to use it, but it isn't perfect and it doesn't fix everything. So sometimes what we're experiencing, how we're feeling, might not in fact be hormone related. It might be due to life stresses. It might have diet and lifestyle factors contributing to it. So there's other things we think about first. But if we are taking it for the symptoms or the consequences, which are clearly related to being low on estrogen, then the first type may not be the answer. We do have to individualize. There isn't one type that suits everyone. So we often start with a daily tablet, but for some women, they don't absorb it so well to get enough into their circulation to have the desired effect. Many women do, and in most cases, we would always start with a low dose, and often just a low dose preparation is enough. When you swallow the tablet, it has to be absorbed through the bowel. It has to then go through the liver where it's metabolized, and sometimes it's broken down too quickly so that we don't get quite enough into the circulation. For many women, though, that's absolutely fine, and that's the ideal for them. If we use what we call transdermal estrogen, so that's when it's going through the skin, and there may be some medical indications to use it that way, or it may be the woman's preference, then the absorption through the skin varies. So some women respond really well to a patch, even a low dose patch. For some women, the gel is better. For some women, the spray is better. So you cannot predict. It is just starting at a reasonable point and then be prepared to adjust. And the other aspect is anyone that we try, whether it's a new type, whether it's a change, we should give it at least 3 months before we decide whether or not a further change is needed. Sometimes I see people wanting to change it after a week because it's not a magic answer. Having said that, some women will come back and say, within a week, I started to notice a difference, but actually it can take fully the 3 months. And I mentioned diet and lifestyle already. Do you know, I see some women that are on a reasonable dose of estrogen, they're still having problems, but there's other factors contributing, such as drinking 2 glasses of wine a night or other stresses that's going on. So we shouldn't focus just on the estrogen. It's part of the whole bigger complex that is our life and that is unique to us.
I couldn't agree with you more. I'm on HRT. But then I do consider what I'm eating, regular diet, managing my stress, watching for triggers like that, because it's an interesting one, isn't it? Because you mentioned about testosterone being in the press, but I also see headlines that make it sound like HRT is the panacea for everything. Don't worry about what your symptoms are or what your long-term risks might be. You can take HRT and it will all be resolved, but you do have to take that more holistic approach. Now, HRT could be absolutely phenomenal, and actually it was for me. I didn't realize how much I was struggling until HRT took away some of those symptoms. But at the same time, you know, you do have to consider other factors too in taking it. So couldn't agree more. But this is all about informed choice, isn't it? That we're looking at here, and thinking about the whole of your life and as you say, other factors. So one of the things that is a frequent question is about the benefits and the risks. Now I know it was 2013, I think it was actually, something like that. I first talked to you about the benefits and risks. because we'd seen so many headlines about HRT will give you cancer, which puts so many people off. And because they were big headlines and still perpetuate to an extent, it still worries people. So can you give us a clearer idea of the benefits and risks of HRT that people can read up on and consider in their choice?
Yeah, so the benefits of HRT are, it is the most effective treatment for treating the symptoms of menopause. And so that's the symptoms of being low in estrogen. And as I said, we're replacing estrogen. So that is the most effective at the moment. Other options can be helpful for women, and women may well choose other options. Some women medically may be difficult to offer HRT, or that may be their preference not to take HRT. So there are other things, but it is still at the moment the most effective option that we have. So that's for the flushes, the sweats, the low mood, the anxiety, the psychological changes that go around that time when our ovarian function is changing and when we're gradually becoming low on estrogen. So those are the benefits. And for most women who have troublesome menopausal symptoms, and remember when I say troublesome, it's also around what are the impact of those symptoms. So if we just have some mild symptoms that we're managing with that are not impacting our life, then we don't have to rush to think about taking treatment. It's when we are struggling. And as you said, Deborah, sometimes you don't realize how much you've been struggling until it's gone, until we've sorted it. So, don't hold back. There are effective treatments. But if we're finding our symptoms are having an impact, that is the time to seek help. And as well as looking at what can we do to help ourselves, but looking at taking treatment. So for women who are having troublesome symptoms, that one of the main indication, the commonly used indication for prescribing HRT is troublesome symptoms for women up to the age of 60 or within 10 years of the menopause, the benefits of controlling those symptoms will outweigh the risks. There are other longer term benefits. So we know that estrogen is really good for our bones. And so for bone health, it's really important as well. And we know it reduces the risk of osteoporosis and osteoporosis-related fractures. And so if, for example, you have a strong family history of osteoporosis, then that and menopausal symptoms, that would be another reason to look at the use of HRT. Another indication is for women who have an early menopause or premature. So having menopause under the age of 40 is known as premature ovarian insufficiency. It used to be known as premature menopause, or under the age of 45 is early menopause. If we lose estrogen at a younger age than normal, we know that significantly affects our heart health risk and our bone risk. And therefore, for younger women becoming menopausal, the recommendation is to offer hormone therapy, even if they're not having troublesome symptoms, but to take it for protection of our bones and our heart, because there is this increased risk of untreated early or premature menopause. And in that situation, the only reason we wouldn't offer it is woman's choice, of course, but also if she has a hormone-dependent cancer, for example, and in that situation, it'd be very difficult to offer HRT. And so these are the main indications: troublesome symptoms, or early premature menopause, or concerns about risk for osteoporosis. So for all these women, there are more benefits than risks. You mentioned risk of cancer, and the sort of history of HRT is back in the 1990s and earlier. There was a lot of use of HRT. It was prescribed with confidence, it was taken with confidence, and we knew that the benefits outweighed the risk. In the early 2000s, we had publication of the trials that you mentioned, referred to, Deborah, around increasing risk of breast cancer. There was huge publicity around that, and that swung the focus away from benefits of HRT to be more concerned about risks. And it's taken us about 20 years to get these risks back in perspective. So where we are at the moment related to breast cancer, I've mentioned womb cancer already, but that's if we give inappropriate treatment with estrogen with not enough progesterone. But related to breast cancer, the current understanding is that if HRT is taken for more than 5 years after the age of 50, and for the younger women, we'll look on it that up to 50, we're just replacing the hormones that would normally be there anyway. And so we start counting at 50. So taking it for a longer duration after that time, there is an association with a small increased risk of breast cancer, which is believed to be due to the hormones promoting breast cancer cells that's already there that haven't yet become clinically evident, rather than causing cells to turn into cancer. So we can't say there's no risk. Women who can take estrogen only, who don't have a womb, who don't need to take progesterone, for them, there's very little risk. There is a little bit more risk if we take the combined HRT, estrogen and progesterone, which is what's required by most women. But getting that risk in perspective, it isn't higher than being overweight or than drinking glasses of wine each night. So, you know, a regular alcohol intake. So there are other risks that we have to get in perspective. And despite knowing that risk, for most women, the benefits in terms of symptom control, improved quality of life, bone health and heart health do outweigh the risks. But we have to keep it in mind, and we have to keep the risk in perspective, but also remember the benefits, which are significant.
That's fantastic. So I'm hearing from you, well, all I'm hearing from you is good news. This is all about informed choice and making the decision that's right for you and thinking more holistically. But, you know, those risks scared so many people about taking HRT. And when you say it's taken us 20 years to overcome those reports, just imagine how many people would have benefited from HRT had those headlines not happened. And the extra thing for me there is we often talk about symptoms, but the long-term health is just as important, isn't it? When your life expectancy is in your 80s, and if you have that family history of osteoporosis, which actually I do, you know, you do want to think, actually, is this something I can be doing to protect myself well into the future? And you mentioned heart and bone health, but the one that's making the headlines at the moment, and we did get a question in about this one, is reports about studies on the relationship between HRT and Alzheimer's are conflicting. I know what you mean, actually, Megan. It's because I've seen the same headlines. Could you please explain the latest thinking on whether HRT options are associated with increased risk of developing Alzheimer's? And is there anything to do with timing? You know, should you take it earlier during perimenopause or menopause to get the benefits of it? And the reason that I understand this question is because I saw one that was saying actually it was the Davina program, you know, that was aired last year, was talking about HRT could help stave off Alzheimer's. And then I read something and it said actually HRT can make dementia worse. And I was thinking, which one is it?
Yeah, so it is confusing. We always want the perfect trial. We always want the perfect evidence that's used. Lots of women, that's randomized, the placebo controlled, but we don't always have that. So we have to make the best guess we can out of the information we have. Overall, the current information related to HRT and prevention of Alzheimer's is that there may be a beneficial effect. And actually, there was another paper produced just this week, I think, published, looking at a gene effect. So there's a certain gene that some women have that makes them more susceptible to developing Alzheimer's disease. And in these women, there is a possibility, but the evidence is not clear-cut yet, that HRT may help reduce the development. But it's not clear-cut to use it purely for the purpose of preventing Alzheimer's in women who don't have menopausal symptoms. So if you have menopausal symptoms, you take HRT. In addition, it's going to give you bone health effect. If you start it within 10 years of the menopause or under the age of 60, it's also going to give you cardiovascular heart protection, and it may do the same for Alzheimer's. So, but at the same time, there's some really good information being published recently. In fact, International Menopause Day in October last year, there was a feature from the International Menopause Society looking at this, in particular, dementia and brain fog, and showing that actually we should be looking on our brain health the same as we look at heart health. So the same things that we should be doing for our heart health, so regular exercise, not smoking, healthy diet, can also be helpful for our brain and our brain function. And we need to do much more focus on what we can do to help that. The information around HRT increasing the risk of dementia was from long-term studies, which has been published within the last few years, showing that long-term use of combined HRT may slightly increase the risk of dementia after 10, 15, 20 years. And so for both heart health and brain health, what my summarizing of it all is that there is this window of opportunity. So if we start HRT early for our menopausal symptoms, because they start early in that transition to going through reproductive years to post-reproductive years, then in addition as helping our symptoms, it's going to give us benefits for bone health and heart health. But we shouldn't be looking at taking HRT forever. There will be a point where we don't need it for symptoms, and at the same time we need to be focusing on our general health and what we can do to keep ourselves as healthy as possible, and thinking about brain health as well as heart health. So there's more research needed. You know, HRT and menopause we've known about for so long, and there's been so much research already, but it's never going to be quite enough to be definitive. And so we can only make the informed choices on the information that's available at the time.
Thank you very much, Heather. And I absolutely agree about the research. But then again, I always do a happy dance when I see a new product come to market with all of the testing and everything, because, you know, there is so much variety now that hopefully if you want to take HRT, there might be something that's right for you, which brings me on to the question of, is HRT available or right for everyone? Can anybody take it?
There are very few women who can never take HRT, but there are some women with certain conditions that we would be cautious about using HRT, either about using it in general or using the type or a certain type or route. And there are many women who just don't want to take HRT, and that's absolutely fine. As you've mentioned already, it's informed choice. But if there is a clear reason, and you know, I don't think we're at the stage of for someone who is not having troublesome early symptoms, they actually feel fine. And there is a little bit of pressure around the place now suggesting even they should take HRT. But actually, what would they be taking it for? They're not going to see any difference. And yes, we could say, well, take it anyway for your bone health and your heart health. But actually, if we focus on our diet and lifestyle, that's going to be good for our bone health and heart health anyway. So we are still there with the sort of menopausal symptoms. So for women who have symptoms, there is a clear indication to take HRT. If there are some medical conditions, so for example, if someone's got risk factors or had a previous deep vein thrombosis, so a blood clot, for example, in the leg, what we call a DVT, a deep vein thrombosis, then we would be wary of using tablet form of HRT, because as the tablet, the estrogen goes through the liver, it can affect our clotting factors and slightly increase your risk of having a DVT, which isn't a concern in someone who has no risk factors for that. But if someone has had a previous DVT or they're significantly overweight, then that can increase your risk anyway, and you wouldn't want to add to that risk. So there are certain things like that that would influence the route of HRT, but it doesn't mean they can't have HRT. I'm struggling to keep up with all the questions, but
don't worry.
About having high blood pressure. So someone having high blood pressure in the past would be told, you can't take HRT because you've had high blood pressure. The first thing is to control the blood pressure, but then absolutely, yes, HRT can be taken. And actually, if you have high blood pressure, that's going to affect your heart health. And actually, starting HRT in those early years can beneficially affect your heart health as well as your bone health. So actually, that might be another reason to think about taking HRT as if you have symptoms. The main concern are those who've had a hormone-sensitive cancer. And we immediately think of breast cancer, but there's also womb cancer, there's some bladder cancers that are hormone sensitive. So there's different types of cancer. And I think we have got much better at testing receptors. So surgery for cancers in the past maybe didn't do as many tests as we do now. So we are picking up cancers that are shown to be estrogen sensitive. So it would be very difficult to justify giving estrogen back to someone who's had treatment for a hormone sensitive cancer. If we are considering that, it would be exceptional circumstances, and we'd have to go through the history, the type of cancer. It would have to fully be discussed with the woman primarily, but also with her oncology team to look at what's going to be the best option, because the worst thing we want to do is increase any risk of recurrence of cancer. And of course, that's where we get into big problems, because there are not lots of trials that there was not good scientific evidence for some of the cancers to know what the outcome would be. But it's just having that discussion, basing it on the information that we have, and also looking at some of the non-hormonal options as well.
Thank you very much, Heather. I have to say, this is a huge area and you're covering so much in such a short period of time. I'm just going to ask my colleague, Sally Leach, because I know she's been watching the questions throughout, so you don't have to worry about that. And, you know, we can't answer individual questions. That will be a conversation between yourself and your doctor. But I'm sure Sally's been looking at the themes of the questions.
I've been trying to see them. There's so many coming.
Yeah, I mean, firstly, just thank you, everyone, because lots of people have been sharing, reassuring each other, sharing their own experiences, and that's what we love on these sessions. It's really appreciated. So I've picked out key themes to say, trying to answer as much as possible. And also in the article following the session, we will signpost additional resources for people to be able to reference, in particular Menopause Matters and the information that's provided. So first question around testosterone. I know we've covered that a bit, but a little bit more clarification around when that might be an appropriate addition for somebody. And can someone take testosterone if they can't take other types of HRT?
So the last bit first, testosterone is actually converted to estrogen. So if there's a reason for not taking estrogen, it kind of doesn't make sense to take testosterone. So that's the easy bit to answer. So the indication is persistent, troublesome, low libido, low sexual desire when everything else has been addressed. And so that means making sure that estrogen has been optimized. So, you know, there's so many things can affect libido that if you are struggling because you're not sleeping well, you're having menopausal symptoms that are making you feel quite low, anxious, depressed mood, all these things that in many women will affect their libido. So that needs to be sorted first. There's also vaginal estrogenization. So sometimes many women find vaginal dryness and discomfort, and that's enough to affect your libido if it's going to be uncomfortable, if you're not going to have the same response. And so vaginal estrogen and regular moisturizers can help with that. The women who are most likely to benefit after addressing all these other factors, you know, not to mention any relationship issues, any just life is too busy to think about sex. By the time you get to bed, you want to have just sleep, or, you know, a cup of tea in the evening, or cocoa, you know, all these old sayings, but actually these are all really relevant because our lives are so busy. And so if we then do have a trial of testosterone, and the women who often we find are most likely to benefit are those who have had a surgical menopause and had the ovaries removed. We'd probably be a little bit quicker in thinking about testosterone in these women. If they're on adequate estrogen, everything else is sorted, but there's still that problem with persistent, troublesome low libido. When we do add in testosterone, it's not a magic answer. So from the data that we have, the best we can expect it to do is help with one extra satisfying sexual episode per month. If you're having no satisfying sexual episodes per month, then that's actually a big improvement. You know, that's a good start. And sometimes then what it does is get back into the routine, because we, you know, bad habits build in. Like, you know, women tell me stories like, oh, I wait till he's gone to bed and I know he's asleep before I go to bed because I don't want anything to be expected or anything to happen. You know, all sorts of stuff goes on that we build into our lives. And so often it can just get you out of that vicious circle, and sex is to be enjoyed, isn't it? You know, and it shouldn't be something that we feel we have to do, but there's lots of other factors. So there's really good video on NHS Inform, another resource around sex, and, you know, using sex toys and all sorts of other things that we can do and think about before adding in testosterone.
Yeah. And someone just asked whether testosterone, whether it helps around brain fog, focus and concentration. The focus of testosterone is around being prescribed to support low libido. Is that
absolutely
correct?
So
yeah.
There are some situations when it is being prescribed for other complaints, but actually there's no scientific evidence yet to show that it is beneficial for that.
Okay. Brilliant. There's a lot around when we should be taking it, when we should be stopping it, coming off HRT, do symptoms all come
Yeah.
back? So a question in particular, if someone's not having symptoms, but they are obviously hearing about benefits of HRT, should they be thinking about taking it, or is it there to manage symptoms?
It's there for symptoms primarily. I mean, there is the risk factors for osteoporosis, and there are the group of women, as I mentioned, with the early menopause or premature ovarian insufficiency, where hormone therapy would be recommended, and recommended to take at least until the average age of menopause, because you're replacing what really would usually be there anyway. But if you're having your periods have stopped, you're in your early 50s, you're not having any symptoms, that's actually fine not to take it. You know, and unless you have a strong family history for osteoporosis, for example, then it's worth having a chat about it. And the other sort of often asked question is, what happens when I do stop it? How long should I take it for? And what happens when I do stop it? So how long? There is no arbitrary limit to the duration that you take HRT. If you're taking it for controlling symptoms, you cannot predict how long the symptoms will go on for. The average duration is around 7 years, maybe less, maybe longer. And so at some point, you might want to have a trial of it for at least 3 months, just to see how you are, to see if you still feel you can benefit from it. When you do come off it, it doesn't mean your symptoms will automatically come back. And even if they do, they may not have the same impact as they had earlier on. I saw there was a chat about taking for 10 years or up to 60. We know that up to 60, for most women, there are more benefits than risks. Some women will continue to benefit by taking longer if they're still having those troublesome menopausal symptoms that are having an impact. But many women will be able to come off it, and either they don't have symptoms come back, or they can deal with them in a different way. Because the other big factor is during this time, our life is changing as well. So the impact may not be the same.
Brilliant, thank you.
And thank you very much, Sally. And thank you to everyone, as Sally said, for all of those questions. What we will do after this session is look to see what some of the key themes are. And of course, we will send on other resources if we don't think that we've given enough information in this session, because there is so much to cover. And my goodness, thank you very much, Dr. Heather Currie, for spending the time with us today. It felt like John Craven's Newsround, for those of us that might remember that, on HRT, and we covered a lot of ground, and we'll keep this information coming. So thank you very much to everyone for joining us, and thanks again, Dr. Currie and Sally, for joining us this set and answering all of those questions. It was absolutely awesome.
Thank you. Thank you, everyone.
Stay tuned for more Lunch and Learns. We'll be doing these throughout 2023, and there are lots of other resources available too on Henpicked Menopause Hub, but also hop across to Menopause Matters. There is so much evidence-based information on the Menopause Matters website. Is that menopausematters.co.uk, Heather?
Yeah, it is. Yeah.
And if you can't get the Menopause Matter magazine, which has got Naomi Watts on the front this time, you can subscribe to it. So that is all on Menopause Matters. So do hop across and look through there too. So thank you for joining us today, and Happy New Year to you. All the best.
Thank you.